Dr. Ashish, are you with us? I think people request you to switch off your videos, please. Those who are presenting alone can be there. Good evening, friends. It's 8 o'clock, and I warmly welcome our senior faculty, Dr. Jailal sir, the invited faculty, Professor Amit Gupta from All Institute, Rishikesh, and I could see Professor Mutish Praya. I think sir joined and he has some issues. We have two cases for this evening. Case number 1 is obstructive jaundice from All Institute of Medical Sciences, Rishikesh, Dr. Ashish. The next case is a loin lump or mass abdomen, renal mass, going to be presented by Dr. Nikunj Patel from BJMC, kindly contributed by Professor Modi sir from Ahmedabad. So, ladies and gentlemen, I also warmly welcome the Professor Ajay Khanna sir, Professor Mutish Praya sir. Dr. Mutish Praya sir is the professor and head of the department from Sri Venkateswara Institute of Medical Sciences, Tirupati. Khanna sir, good evening, sir. So, Dr. Ashish, kindly share your PPT. Please introduce your unit chief, your head of the department, and start your presentation. Dr. Ashish?
Yes, sir. Sir.
Can you please switch on your video first?
Good evening, sir. Sir,
Neha ma'am, good evening.
Hello,
Neha
sir.
ma'am is from Kanpur. She is a surgical gastroenterologist. Thank you, ma'am. Thank you for joining us.
Thank you, sir.
Yes, ma'am. Ashish, you have any challenges, ma'am?
sir, I'm not able to share the screen. I'm trying to share, sir.
No, I am enabled to share, permitted to share, but we are still unable to see you. If you have challenges, I can request Dr. Nikunj to present first. Dr. Nikunj, are you ready? Dr. Nikunj Patel?
Yes, sir.
Okay, you please start your presentation, Dr. Nikunj. Ashish, let him settle down. Ashish, I request you to update your Zoom and re-log in again.
Okay, sir.
Nikunj, you try, open up your video, Nikunj.
Like you have not seen your...
Can you switch on your video, Dr. Nikunj?
Yes, sir.
Okay. I request people who are not presenting and not faculty to please kindly switch off your audio. Dr. Nikunj, are you with us?
Yes, sir. Good evening.
Yes, I'm able to see you now. Good luck to you. The faculty who have joined us today, madam and sir, like the candidate will be presenting through the history without stopping. At the end of the history, they will sum up and you can take back to their first slide onwards and ask questions to that. The invited faculty take preference and our own senior faculty will also supplement their questions. And then once they finish the history part, then they will be allowed to present the clinical findings without stopping anywhere. At the end of diagnosis, then you can revisit all the slides and ask questions and give your comments at every slide. So we have about half an hour to do this. And then next half an hour will be assessing the candidate based on their investigation plan, management, and then you can also ask up to the recent advances. We have 1 hour for each case. So at the end of 1 hour, you please give your summing up comments. The candidate will be also allowed to ask any doubts to be clarified at the end of that. And then we move on to the next case. Thank you, faculty, for kindly joining us and accepting our invitation. So, Dr. Nikunj, you can introduce yourself, your unit chief and head of the department, and start your presentation. Good luck to you, Dr. Nikunj.
Thank you, sir. Good evening, everyone. I am Dr. Nikunj Patel, second year resident in BJMC Ahmedabad. I am a surgical resident under Dr. Pankaj Modi, sir. And today I will be presenting a case of abdominal lump. So in my case, sir, 60-year-old male patient belonging to low socio-economic class residing in Madhya Pradesh, presented with the complaint of a lump in left loin since last 3 years. Patient was relatively asymptomatic before 3 years. Then he noticed lump in left loin, which was insidious in onset and slowly increasing in size, which was only associated with the burning micturition on and off, without any association with any abdominal pain, fever, hematuria, bleeding per rectum, constipation, diarrhea, vomiting, weight loss, jaundice, increased frequency of urination, hesitancy, or pyuria. Patient has no comorbidity, no history of allergy, no past surgical history. Patient is on mixed veg diet with alcohol and tobacco chewer with BD smoker since last 40 years. Patient is having adequate sleep and appetite with regular bowel and bladder habit. There is no significant family history. So summary of my history, sir. 60-year-old male patient from Madhya Pradesh without any comorbidity, presented with the left loin mass, which was insidious onset with slowly progressive, with on and off burning micturition since last 3 years.
Okay. Ashish, how do you come to know it is a slowly growing left loin mass?
That as a patient is having complaints since last 3 years, patient has said a patient was able to felt the swelling in left loin before 3 years, and then it was gradually progressed since he noticed the swelling. So, sir, it is duration of the symptoms.
No. How a patient notices swelling in the loin?
Sir, patient experienced fullness in left loin, following which he was able to he noticed the swelling, sir, in left loin, sir.
When 3 years back?
Yes, sir.
Now what is the size of the swelling? Same?
No, sir, it has increased. Patient is saying that since he has noticed the swelling is progressed in size.
So what do you mean by loin?
So loin is sir, in layman language, a part of the...
We are talking about scientific terms, not layman. So we are presenting in the present history, no?
Yes.
So what
Sir,
you understand, which part you said is a loin, he has a swelling?
Lumbar region, sir.
Bounded by?
Sir, superior lumbar region is sir, bounded by superiorly by transpyloric plane, medially by the mid clavicular line, and inferiorly by the transtubercular line.
So do you expect a swelling when you're seeing anterior abdominal wall from the loin? It could be a renal swelling?
Yes, sir.
So renal swelling normally goes posteriorly, you feel more, or anteriorly you feel more?
So posteriorly, in a renal angle, sir, we can feel the renal swelling more.
Okay, but I think you must have asked the history properly. But normally a loin swelling in the early part, understanding by feeling by the patient is a very, very rare. That to be noticing a swelling is a difficult one. Probably your patient has seen and informed to you. Dr. Amit Gupta, sir, you can ask questions and so your voice is not here. Nikunj, can you make
Yes.
to the first slide?
Go back to
From your history,
Yes, sir.
can you make any suggestions or any diagnosis based only on the history?
From the history, sir, it is patient, sir, swelling is associated with the burning micturition and associated with it is also very slow growing, sir, sir, mass in left lumbar region and not associated with any fever, weight loss or any hematuria. So it is likely to be, sir, a benign renal lesion or swelling, sir.
Can you tell at the age of 60 years, what can be the benign renal lesions? He's presenting at the age of 60 years, isn't it?
Yes, sir.
So what benign lesion can be there at the age of 60 years?
Sir, it can be due to hydronephrosis secondary to calculi, ureteric calculi or calculi obstructing pelviureteric junction. Other than that,
Does
it
he
can
give
be
history of the calculus pain? Jay?
No, sir.
Has he ever given the history of calculus
No,
type
sir.
of pain?
No, sir.
There is no history there.
No, sir.
Okay.
Sir, patient can also have adult autosomal dominant polycystic kidney disease, sir, which has, sir, onset, sir.
no. Why did you think of only renal mass? Why not other masses?
Yes, sir. It can be due to mass arising from suprarenal gland, or it can be due to descending colon mass, descending colon malignancy, or it can also be due to spleen, and sir, rarely due to retroperitoneal sir, tumor.
Is this swelling in the upper part of the abdomen or lower part or in the middle part?
Sir, middle parts.
Middle part. So if you think it is after the kidney, you said it can be adrenal mass. So that is the site for the adrenal mass, the middle abdomen.
Sir, left hypochondrium, sir.
That is not the middle abdomen, is it?
No, sir.
You said burning micturition on and off. What is that you mean?
So patient can be experiencing recurrent urinary tract infection.
What is that frequency? What is that on and off means?
So patient was saying that during these 3 years of time, he has experienced 3 to 4 times burning micturition, sir.
So if the patient comes 3 years period, 3 times episode of burning micturition, do you attribute to the significant? When you don't drink water adequately, when you are dehydrated, also you can have, or when you have a urinary tract infection, you can have. Why do you want to contribute this to a lesion, big lesion, and taking it as a body? Is it a hematuria?
No, sir.
How do you know it is not a hematuria?
So patient was saying that there was no frank blood in the urine. Microscopic hematuria can be there, sir.
No, that is not a question was asked to you.
Yes,
Why, can you rule out hematuria? What was the color
No,
of the
sir.
burning micturition urine?
Sir, straw yellow color urine, he was saying that, sir, dark yellow to straw yellow color urine, sir.
No, you need to ask little more because you can't take it just like that when the burning maturation on and off. You must, because that is only complaints which is going to lead you to the renal mass. So you need to elaborate on that. What was it, associated pain, and how it was the frequency, and what was the color? Is it any times associated with hematuria? Is it with the pain? And is it a hematuria is coming earlier part, full stream, or part of it? All this is important history we have to elicit.
Was the patient has got any fever associated with the fever?
No, sir.
Anytime?
No, sir. Patient was saying that there is no episode of fever in last, sir, 3 years.
What is Dittle's crisis?
Sir, details crisis is sir sudden. Sir, patient was unable to pass urine due to renal calculi, and sir, after that, once the obstructive features of calculi sir, subsided, the patient passes large amount of urine with sir palpable lump being disappear.
Okay. Tell the various conditions of abdominal lump, which you may find that they decrease in size all of a sudden.
Yes, sorry, sir.
Abdominal lump is there, the patient feels at one time,
Yes,
and
sir.
then it has almost disappeared.
What are the possibilities you think?
Yes, sir. Sir, first of all, details crisis in that, sir.
That already you have said. You have to go ahead with other answers.
Sir, enteric mass, sir, gastric, sir, partial gastric outlet obstruction.
No.
Amit Gupta, sir, you are not audible. You are put that question. Your voice is not here. Dr. Amit Gupta, sir. You can go ahead. Anything related to the intestine can produce a mass which is.
What can happen in interception? Interception, what can happen?
Sir, part of the small bowel or sir, part of the large bowel, sir, goes sir into the distal part of sir small bowel or large bowel, sir.
No.
Yes,
Can it
sir.
happen in interception or not?
Yes, sir. It can happen, sir.
Okay.
Can you go to your slide, first slide? Is the first slide?
Yes, sir.
Yes.
Next. Next. Why do you ask for bleeding per rectum with this case?
The patient was having, sir, left lumbar mass, sir. It can be arising from the, sir, colon also. So, sir, bleeding per rectum with, sir, constipation. Sir, I have asked. Patient can also have, sir, diverticulitis or.
No, you asked constipation and diarrhea. Both you are asked.
Yes, sir.
For the same reason you are asked.
Yes, sir.
So colonic mass will present both as a constipation or the left-sided colonic mass will present as a diarrhea also.
Sir, patient can present with the constipation more frequently, but sir, if a patient was having, sir, diverticulosis with sir inflammation, it can present with the diarrhea also, sir.
Without fever.
But in diverticulitis, they will have pain abdomen. It's short duration.
Yes.
Short duration.
Because what happens to the bowel habits in a case of a left-sided colonic malignancy?
The patient will have, sir, tenesmus, sir, urgency to pass stool with, sir, hematogagia, passage of fresh blood per rectum, sir. With
What
increased
about the bowel?
frequency of, with
What about
increased,
the bowel habits?
with, sir, increased frequency of, sir, passage of small amounts of stool, sir.
Left-sided colonic.
What is the
Left side,
alternating bowel habit? What do you understand by that? What is the difference between the altered bowel habit and the alternating bowel habit?
Sorry, sir, I don't know.
Okay, altered bowel habit is that somebody is constipated, now he's having diarrhea. Okay, or somebody is having the diarrhea, now he's having constipation. But the alternating bowel habit is that for some time he has the diarrhea and then the constipation, then diarrhea, then constipation. or constipation first, diarrhea after that. So that typically happens in the left colonic malignancy. So why does that occur?
Any inflammation taking place because of obstruction, streptococcus colitis, or anything happening?
You know what is stercoral ulcer?
Yes, sir. Because of sir patent ileocecal valve with left side malignancy being a constricting type, sir, there is gross dilatation of sir cecum with ulceration in cecum, sir, predominantly in cecum, sir, which is called as a stercolic ulcer, sir.
What is scabella? What is scabella?
Sorry, sir, I don't know.
Scabella is the hard stool, you know. Hard stool
Yes.
is the scabella, and the stercoral ulcer occurs because of that scabella which is there. There's a hard stool is there. Okay, and these stercoral ulcers, they produce a lot of the mucus, and that is why these patients, they have a not a real diarrhea, but it is a false diarrhea, pseudo diarrhea is there. So the patient gets constipated because of the type of, what is the type of the growth on the left side?
Constricting type, sir.
It is a constricting type. And what is the lumen of the left and the right side? What is the difference?
Sir, right side colon lumen is, sir, more than sir left side.
Yeah, so because of the type of the growth, because of the lumen which is narrow on the left side, and the type of the stool which is there on the left side, that is the hard stools are there, or it is formed stools are there. And these are the reasons that why these patients, they have the constipation. But because of those stercoral ulcers, they develop the pseudo diarrhea. So you get the alternating bowel habit in the case of the left sided as compared to the right side, where you can have the altered bowel habits. Okay.
Yes.
When will you have this furious diarrhea or diarrhea, pseudo diarrhea? It's a day, morning or evening, night? What is good morning diarrhea? So this invariably takes place in a colonic mass or obstruction. It will be usually a good morning diarrhea. He sleeps in the early morning, he goes to the toilet with always passing a mucus membrane. But the same thing, if it happens more on a night, the mucus, it is more in favor of a IBS, irritable bowels. What is this frequency and hesitancy? What do you mean by frequency of urination and hesitancy?
So frequency is, sir, amount for how much, sir, for how many times patient has to pass urine, and hesitancy means when patient was having urge, is he able to pass urine immediately or after some time because of, sir, hesitancy.
No, why do you ask that? What is urgency?
Sir, urgency is, sir, urge to pass immediate urine, sir.
So urgency is normal.
No, sir. Urgency.
Urge for passing urine is a normal physiology.
Sir,
Fine.
urgency is patient. Sir, these are the symptoms of lower urinary tract, sir, involvement, sir.
So can a diabetes mellitus produce frequency of fever?
Yes, sir. It can.
So without any urinary tract involvement, systemic disease can also produce a frequency of urination.
Yes.
Nikunj, why you are asking history of pyuria?
The patient was having complaint of, sir, burning micturition, and sir, sir, there is chance that sir, infected urine or pus, sir, pus can.
Was there any significant?
Sir, not audible.
Only 3 to 4 occasions he had symptoms in last 3 years. Diagnosis you want to make if you get a history. Am I audible now?
Yes, sir. Yes, sir. Now audible.
It is breaking voice. Some.
Okay. Nikunj, what will be your diagnosis if suppose patient is giving you history of pyonuria?
Sir, with these history, sir, with pyuria, I will consider sir, pyonephrosis can also be one of the possibilities in this case, sir.
For 3 years, you
So
think that
can you
pyonephrosis will be
see-
there? Hello?
Long duration, 3 years, progressively increasing lump without fever. Okay, you don't mix too many things and don't try to, you can just say the bowel habit is normal, maturation habit is normal, instead of putting into that, all that, what not necessary, you follow the same dictum of every word which is there in the textbook has to be repeated here. If you are convinced there's a past history, the bowel habit is normal, then mention only like that. Don't say constipation, no diarrhea, no constipation. Instead of say if it's a normal bowel habit, maturation is normal, you will not get into all these questions which is not related to your presentation.
Yes, sir.
Yes. Yes.
Nikunj, why have you asked about jaundice? Am I audible?
Yes,
Yes.
madam.
Yes.
Why have you asked about jaundice in the patient with a lump on the left side?
Left side lump, you also said retroperitoneal mass, but
Yes,
you
sir.
never asked any question related to respiratory system. You are focusing only on urinary tract and GI tract. But
Can you think in terms of jaundice to the splenomegaly?
What, sir?
With one of the differential, this you thought now the splenomegaly.
Yes, sir.
Would it be explained to your jaundice here?
jaundice, can it be explained in the terms of a splenomegaly?
Sir, hemolytic, sir, patient with the hemolysis can be having, sir, jaundice, sir, with splenomegaly.
But duration of the mass is 3 years, no?
Yes, sir.
So can we pass on to the clinical examination for the patient? Yes.
So Nikunj, one thing is very clear that with this history presentation, actually, we are not able to make any diagnosis, right? So as Dr. Ajay Khanna also pointed out that some diagnosis you should make based on the history alone, right? Without going into the examination part. Is that clear?
Yes,
So
sir.
something must be in your brain what my patient is suffering from. So by this presentation, actually you are nowhere, right? You are not leading to any clue that what my patient, this patient might be suffering from, right? So this should not be the case when you are actually presenting a history, right? Some clue you should get. And if you are suspecting a retroperitoneal mass, definitely yes, you have to rule out all the metastatic symptoms as sir rightly pointed out just now. You should have taken history of metastasis to lungs or thorax, so difficulty in breathing, hemoptysis, etc. Right?
Yes, sir.
Okay, go ahead and start with your general physical examination, please.
Sir, I have examined my patient in proper light exposure in standing and supine position after taking verbal consent. Patient was conscious, oriented to time, place, and person. There was no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or edema, sir. Patient temperature was normal. Pulse rate was 80 beats per minute in right radial artery, which was regular, with blood pressure of 100.
Nikunj, let me interrupt you here only that see actually in general physical examination, before telling pallor and icterus, etc., you need to tell the vitals, right?
Yes.
Anyway, carry on.
So patient blood pressure was 110 by 70 millimeters of mercury in a right arm in supine position with respiratory system bilateral air entry was normal, sir. on sir, local perabdominal examination on inspection. Sir, the patient was having sir, flat abdomen with centrally placed inverted umbilicus with all the quadrants moving corresponding with the respiration without any scar, previous scar, redness, dilated vein, or visible pulsation or peristalsis or lump. There was no organomegaly visible, and there was no visible cough impulse present at hernial orifices. So on palpation, there was normal temperature and so there is no tenderness. A single 9x7 centimeter non-tender, well-defined, smooth, firm lump present in the left lumbar region, becoming less prominent on straight leg raising test. Lump is bulletable with insinuation possible without moving with the respiration. And sir, liver and spleen are not palpable with hernial orifices are intact.
So,
So my provisional sir, diagnosis is sir, left benign renal mass, or it can be a retroperitoneal mass. Sir, on percussion, sir, dull knot present over lump with the rest of the abdomen having tympanic knot with a liver span of 30 centimeter in mid clavicular line with normal peristalsis on auscultation. Per rectal examination was normal. So my case summary of this patient, 60-year-old male patient without comorbidity, presented with a 9x7 centimeter non-tender, well-defined, firm, bulletable lump in left lumbar region, not moving with respiration, with dull knot on percussion. So probably of mass of benign renal origin.
Nikunj, you are thinking in terms of a kidney left side, but you will not examine the scrotum, not examine the testis, not examine the spine. And how do you suddenly say when you are thinking a mass in the left side kidney? Don't you think some changes will happen place in the scrotum?
Nikunj, what changes in the scrotum you are expecting in such patient or in inguinal region? What changes you can observe? Go back to your inspection, please.
Yes.
Show your inspection slide. Inspection abdomen.
So this is the inspection with the arm raised. Why do you want to keep the arm raised for the inspection?
Yeah, previous slide, please.
previous slide.
Okay. So as per this slide is showing, have you inspected the back of the patient? Because by this slide, it doesn't appear that you have looked the patient's spine or patient's renal angles, whether there was any fullness there or not. And then you are trying to make a diagnosis of renal lump, right?
Yes.
Right. So abdomen doesn't mean only the interior abdominal wall, right? So it's a three-dimensional box-like structure you have to see for posterior abdominal wall, right?
Yes.
In the
That's a
history,
part and parcel.
patient has noticed a lump, but you are not able to notice a lump. The history was stated that patient has noticed a lump.
Yes.
Going slowly.
Yes.
The patient is able to notice a lump, but you are on inspection, you couldn't see a lump.
No, sir.
So I think in the inspection, you have to examine the external genitalia as well as the renal angles posteriorly. Yes. You should comment.
Yes.
Then left supraclavicular region also. At least juxtal genitalia. What do you look for in juxtal genitalia? Inspection.
Have you had varicocele?
Yes, sir. Sir, Yes, sir. I will look for, sir, varicocele, sir. Sir.
Testicular tumor size, I think.
Yes, sir. Sir, if sir, testis size and varicocele, I will notice, sir, as a long-standing, sir, varicocele secondary to any renal pathology. As left side.
How confidently you are saying by inspection there is no organomegaly? Do we look for organomegaly by inspection normally?
No, sir. On palpation, sir.
So you are committing that there is no organomegaly. Your next slide says there is a renal lump. Next slide.
So sometimes.
We put the next slide. Huh?
Yes.
Next slide. Next. Look up.
Nikunj,
Yes.
you have mentioned that insinuation is possible. So insinuation of what and where?
Sir, insinuation at sir left costal margin is possible, sir.
So insinuation of your fingers is possible at
Yes, sir.
left subcostal margin.
Yes, sir.
So what does that mean? What it implies?
Sir, it implies that sir lump is less likely to be arising from spleen, sir.
And before that, you have mentioned that lump is ballotable,
Yes, sir.
and then it is not moving with respiration. So do you think that these things are going in favor of it being a renal lump?
Yes, sir.
So generally renal lumps move with respiration or not?
Sir, usually it slightly moves with the respiration, but not as much of as a lump arising from spleen, sir.
What do you
So one
mean?
different. Yes, sir, please.
Yes, madam, please ask.
So I was asking that you have placed a differential of a retroperitoneal mass as well. Do you
Yes, ma'am.
think that will be a blottable mass?
No, ma'am. Retroperitoneal mass are fixed, ma'am, and will not be ballotable with no movement with respiration, ma'am.
Is it bimanually palpable?
No, ma'am. No, sir. It was not bimanually palpable.
The
But,
great hero back.
So it was not bimanually palpable, but sir, a lump was ballotable, sir.
So you should mention that also. Whether the lump is bimanually palpable. What is the major difference? Bimanually palpable and ballotable?
Sir, bimanually palpable means patient, sir, when we put, when I put, sir, my sir left hand, left fingers below the sir posterior aspect of costal margin, and sir, my right index finger over the lump, it can be palpated by both hands, right and left, simultaneously. While in case of ballotable lump, when I push my finger forward of left hand, lump will become defined on anterior aspect by my right hand.
Again, are you going to palpate with a finger?
Sir,
Is the ballotability you are going to palpate with a finger or hand?
hands.
But you said index finger you are going to keep.
No, sir, whole hand, sir. Sorry, sir.
So that is very important when how you are, because the way you are presenting that we are not confident that how you have really seen the ballotability. I felt the palatability. Because you are not visibly examining the renal angle, posterior part. Then how do you able to see that there is a mass and immediately going for a palatability test? No, why? What you said, the mass is becoming less prominent on straight leg rising. What does
Yes.
it indicate?
So it indicates the lump is being lump is from intra-abdominal compartment. Sir.
The lump already in the inspection you are not able to feel, see. Now only you are feeling a small lump inside. Can you able to appreciate the size of the lump is decreasing? So by your leg rising, the 6 centimeter tumor is becoming 3 centimeter tumor. So that test we do only when your mass is visible on your inspection. Because if abdominal or extra-abdominal, you will there rising the leg will differentiate. Here the mass is only palpable. So there will not be any change which will happen in the size of the mass. So this test should not be valid on.
Yes.
Okay.
Yeah, Nikunj, I just want to ask you one question.
Yes.
Is this a real patient or is this just a hypothetical history you have prepared?
So this is a real patient, sir.
And you have yourself examined this patient?
Yes, sir.
Okay. So actually there are a lot of inconsistencies in your inspection as well as palpation, right? And sir is very rightly pointing out that when you are saying that you cannot see a lump on inspection, then now on palpation, but you are very confidently saying that lump is becoming less prominent, right? So this goes actually against your inspective findings, right? So there is a contradiction in that, right? And whenever you are describing any lump which is palatability, having palatability, you should also make a comment whether it is bimanually palpable or not, right? You cannot do away without that. Yeah. Dr. Kanagavel? You
Sir,
want to ask?
Sir, I'm with you, sir. No, sir, I'm listening to you. Please go ahead, sir.
Yeah. Nikunj, go to your next slide.
Yes.
Yeah, next slide, please.
Sorry, sir. This slide.
And this gentleman is 60-year-old, right?
Yes, sir.
And writing like in digital rectal examination, normal and no prostatomegaly is not sufficient, right? Do you think that patient will not have any enlarged prostate by this age? At least grade 1 prostatomegaly should be there by this age, right? Patient may
Yes.
not be symptomatic for that, right?
Yes.
And in auscultation also you are mentioning peristalsis normal.
Yes.
So in auscultation, do you hear what? Vowel sounds or peristalsis?
Bowel.
Vowel sounds.
So there are discrepancies, huh? Lot of inconsistencies coming up, right?
Yes.
So,
Sorry.
what about the percussion in the renal angles as well as is there any shifting dullness in the abdomen? Renal angles have percuss.
No, sir.
So you have not done actually percussion over the back, so you cannot make a comment on that, right? But theoretically, I am asking you a question. Suppose it was a renal mass and you
Yes.
are percussing over the back, then what finding you can elicit?
Sir, dull note over the sir renal angle, sir.
So dull note, and more importantly, there will be a loss of colonic band of resonance, right?
Yes, sir.
Okay, next slide.
What do you mean by renal angle?
The renal angle is sir between the lowermost sir rib and sir vertebra.
Vertebra. No.
12th rib and sir vertebra.
How do you see the vertebra? Which part of the vertebra? No, that is why you are not examining, because you are not knowing that boundaries or anatomy. That's why you're. Can you say the previous slide? The picture you have seen. So where do you see the renal angle here? This is within your drawn picture. And
Yes.
it shows the line goes along your costal margin. Is it a mark you are describing, or it's a costal margin you are seeing? Yeah, renal lump cannot be always below the costal margin, no?
Yes.
If it is not an or unascended kidney.
Yes.
Because your picture of the mass source, it is goes along the renal curvature, sorry, costal margin, and then.
So Nikunj, go back to percussion. Percussion. Okay. See, actually, you should ideally mention about presence or absence of free fluid, right?
Yes.
So whenever you are describing abdominal lump, never forget to make a note of free fluid, because by these lines it appears that you have never actually looked for free fluid in the abdomen, right? So it may be absent, but that you have to mention that on percussion there was no free fluid found in the abdomen. Is that clear?
Yes, sir.
Dr. Kanagavel, you agree with it?
Sir, I am with you, sir. I am with you perfectly.
And
Yeah.
Nikunj, the dull note over the lump, when you are percussing it anteriorly, do you think that there won't be small bowel above it to percuss and there will be a dull lump, percussion on the lump? You're saying that the lump is dull on percussion. There will be small bowel above it, definitely, and the large bowel. So it won't be dull on percussion anteriorly. Definitely, sir was saying that at the renal angle, when you percuss, it will be a dull note.
Yes.
Since you have said it is a palatable mass, definitely there will be something is there.
Yes.
Is there there? No. So these all are the areas where you need to concentrate, and examination is you need to go in a very, very structured, organized way. So with this finding that what is your, so you are not examined the spine, you are not examined the supraclavicular area, you are not examined the scrotum. The 3 years are mandatory examination, spine, scrotum, and the supraclavicular. Yeah, you need to examine for any case, any abdominal mass you are presenting.
Yes.
So what is the probable diagnosis you might know?
My provisional probable diagnosis is sir, benign renal mass.
Nikunj, that is not a diagnosis, right? Benign. What is benign renal mass? Okay, just name some masses, benign masses at this age in male patient you can come across in relation to kidney.
Sir, simple renal cyst, renal cell carcinoma, hydronephrosis.
Is it benign?
Renal cell carcinoma is
No. Sir, pelvic junction obstruction.
Something fatty tumor.
Sir, angiomyolipoma.
yes.
So yes, angiomyolipoma is an accepted diagnosis, right? Other than that, anything? So Nikunj, you should be prepared well, right? Because after this examination part, your viva actually goes for theoretical knowledge, right?
Yes, sir.
So you should be well versed with your topic, right?
Yes.
Amit sir, I request you give him a working diagnosis and take him further, sir.
Okay. Is it a possibility that patient is still having a hypernephroma or a malignant renal mass arising from kidney? And in this patient also, can you put this diagnosis? Is there a possibility?
Yes, sir.
So what is the scenario?
Sir, patient is having sir left lumbar mass with a burning micturition. Sir,
See, in many cases, you see clear cell cystic carcinomas of kidney, which are actually slow growing tumors, right? So in
Yes.
those some small subset of patients, you can have this kind of presentation, right?
yes, sir.
But when you are presenting a history at some forum or in exam, you should always come to the diagnoses which are clinically more common, right? You should have a look for rare or rarer diagnosis, right?
Yes,
But with this presentation, what complaints you have mentioned, what findings you have mentioned, so actually it is leading nowhere, right? So angiomyolipoma is one, and second possibility we can take about that clear cell cystic neoplasm of kidney, right?
yes.
Yeah, Dr. Kanagable, you want to add some more diagnosis
No,
or
sir.
any?
Sir, we have another 10 minutes only left for this. So
Yeah.
we'll give you one working diagnosis of hypernephroma and take it
Okay.
through that investigation part of it, sir.
Okay, Nikunj. So take it as a hypernephroma.
Yes,
Then how will you proceed to confirm your diagnosis?
Sir, I will do sir routine investigation. First of all, sir, X-ray KUB. Then sir, sir CBC with
X-ray, KUB and CBC are informative. Will they confirm the diagnosis?
no, sir.
So why you are answering like that?
Nikunj, the question from sir was very clear. He wanted you to tell the investigation which will confirm the diagnosis. Please understand, they are not going, they are trying to help you to take you closer to the diagnosis much faster. It is implied when this question is asked, you have done all your basic investigations. All right.
Yes.
So you have all the available investigations at your disposal. If you are the consultant or if you are the teaching faculty, if the patient is come to you, for the sake of patient, what will be your next course of investigation? Question is very clear. You should be able to help you to make a decision in one go.
Sir, I will do sir ultrasonography abdomen pelvis followed by sir confirmatory by sir contrast enhanced CT scan, sir, of this patient. Sir.
Okay, what information you can gather on USG abdomen?
Sir,
Suppose this is a mass arising from kidney itself, right? Left kidney.
yes.
Then what can be the possible findings which you can elicit on ultrasonography?
Sir, I will look for the way at from which area the mass is arising from, sir, of which kidney area mass is arising, upper pole, mid pole, or lower pole. Is it with sir increased vascularity or not, sir?
Please go ahead, ma. You have stopped only with 2 characters of the tumor. A renal mass has multiple characters.
What are the findings in the CT you will expect? It is a renal more in favor of malignancy.
Sir, patient with sir microcalcification present with sir upper renal.
You say calculi inside the this kidney. Do you think seeing a calculi, what we will think in terms of malignancy as a first diagnosis? What will be the size of the tumor? What is the complexity? How much of the fat will be there? What is the degree of contrast uptake?
Okay, Nikunj, I will streamline you. See, first you tell about the location, perfectly understood. Then size. Then you tell whether it is a well-defined or a poorly defined, whether the capsule is intact or capsule is not there at all. Then is it standing apart from the renal parenchymatous tissue? Because in CT, the enhancement varies if you are taking a cortex, medulla, or the pelvis. If there is a tumor, the onset of enhancement varies depending on the type of the lesion, whether it is a hypervascular lesion, avascular lesion, depending on that. In your arterial phase, then in the venous phase, and the diuretic phase, when everything contrast runs off. So the renal protocol CT also helps you to understand what type of lesion it is. And then, as all the chiefs here are asking, there are some specific characteristics in imaging which almost confirms a diagnosis of malignancy, because they are trying to take you to the next question: will you do a biopsy or not? So I would appreciate if you can list out the potential imaging based signs and like signs which you can see in the CT or ultrasound. Then the faculty here will take you further.
Nikunj, are you aware of any CT nephrometry score?
I have a CT image, right?
Yes.
Please put
Yeah,
up.
just show.
Okay, now can you read the CT? That makes life easier.
Yes, sir. There are multiple cortical cysts in all ports of left kidney, with largest being 12 into 10 centimeter in upper pole of left kidney, with left pelvic junction calculi of 8 into 6 mm, with mild fullness of pelvic LCL system, with right kidney measuring 8 into 5 centimeter, with left kidney measuring 9 into 5 centimeter, with mild prostatomegaly with projection of medial lobe prominence and indentation over base of the urinary bladder without any focal liver or liver lesion, lymphadenopathy or ascites.
No interlift changes.
Yeah, Nikunj, actually now these findings are in contrast with your symptomatology, right? Now you are mentioning about prostatomegaly and medial lobe prominence, which is indenting on the base of urinary bladder. So with these findings, we expect that patient must be having symptoms of bladder outlet obstruction, which you are not mentioning in the history, right?
Yes.
Yes.
Okay, now would you like to have a revision in your diagnosis? Would you like to swap, or you would like to add choice B or a choice second pathology to what we have been discussing so far?
Yes, sir. It is, sir, due to hydronephrosis, sir, secondary to the.
What are the secondary changes of hydronephrosis long-standing?
Sir, thinning of cortex of renal with
But your kidney size is only 9 into 5 centimeter.
yes, sir.
You still call it as a nephrosis, hydronephrosis.
Sir, simple renal cyst, sir.
Yes.
You think the content of the cyst is simple?
Is it a clear?
Is it a clear cyst? What is a HU they have mentioned? They have not mentioned the HU of the.
No, sir.
What is HU?
Hounsfield unit, sir.
So for water, what it is?
Sir, for water, it is, sir, 0. For
air?
Which is more air, fat?
Air, fat, water, bone.
Sir, for air, sir, is -100, sir.
For bone?
So bone is, sir.
This patient has a PU calculus. What will be the HU of this calculus?
Sir, sir, greater than, sir, 1000. So
Okay.
bone.
That's fine. That's fair. So with this, do you want to still stick on to obstructive uropathy and retrograde hydronephrosis, or you want to give a differential diagnosis now?
Sir, simple renal cyst, or it can be due to, sir, autosomal dominant polycystic kidney.
With only one cyst.
Is it usually polycystic will be bilateral, no?
Yes, sir.
Nikunj, can you put a diagnosis of renal hydrated cyst in this gentleman as a differential?
You say yes or
Yes,
no.
sir. Yes, sir. Yes, sir.
What are the points in favor? What are the points against? Hydrated, what are the core components in CT you will be expecting?
Sir, membrane will be there with the daughter cyst.
Okay.
With sir, some hydrated sand will be.
1 minute. What are the conditions in hydrated where you don't get to see the membranes? Is there anything, any time possible like that?
Yes, sir. When sir, cyst is sir calcified.
So there is no living broods inside the cavity at all.
Yes.
Right? All the cyst walls have been degenerated, all the daughter cysts have got degenerated, and only the dead and liquid content remain. Then also it can present like this.
Yes, sir.
Anything else which can contest against hydrated?
Sir, there is no primary liver lesion.
Why you should expect a liver lesion at all? Can it be an isolated renal hydrated?
Yes, sir, it can be.
How does hydrated gets into the kidney?
Due from bloodstream.
What is the primary host?
Yes, sir.
Primary host.
Primary host.
Primary source.
Host.
Host, sir, it is sir goat, sir. Sheep.
What is the human is the primary, secondary, or end host?
Sir, and host.
What is end host?
Sir, we are the accidental, sir, humans are the accidental host of the.
Yeah.
What do you mean by end host?
Sir, sir, larva, sir, will not, sir, excreted from, sir, human excreta. So it will not infect.
Further procreation is not possible. That is the end of the entire life cycle of the parasite, because there is no exit point for the parasite to go and multiply with somebody else.
Yes.
All right.
Yes.
So it's a dead end for parasite.
Yes.
Okay, Dr. Kanagavel, can we start with next case?
Sir, let him finish, sir. I think they have the operative images also, because I
Okay,
think he
okay.
has the pathology
Okay.
report also, sir. Go to the next slide, Dr. Nikunj. Quickly tell, were you there during the surgery?
Yes, sir.
So what was the finding and what was done? Quickly tell about what, briefly tell what procedure was done at all.
Sir, partial nephrectomy was done, sir. After, sir, removing the, sir.
Can you quickly tell what was the position of the patient, what anesthesia was given, and what incision was made, and how do you reach the cyst?
Sir, in supine position, in general anesthesia, in upper midline incision was kept, following which, sir, after Mattox maneuver, sir.
What is Mattox maneuver?
Sir, mobilizing the splenic fracture of colon, sir.
What is Cattle's maneuver?
Sir, mobilizing the ascending colon with cecum, sir.
What is Coccus maneuver?
Sir, Koch's maneuver is sir, mobilization of sir duodenum.
What is the medial most limit of Coccus maneuver?
Sir, aorta. Sir, medial most part of
No.
sir, left side of the aorta, sir.
The end of IVC, right? That's the right way to tell. We don't mention aorta as the limit of cauterization. Depends on what type of tumor and what type of surgery you're doing. Okay, good. So what was the finding? So you made a midline, you located the tumor. How did you get the vascular control prior?
Sir, vascular, sir, we have, sir, remove the content of the cyst by aspiration, and following that, sir, partial nephrectomy has been done, sir.
What was the indication of surgery for this patient? You are repeatedly saying it's a simple cyst.
Yes, sir.
So what made you to think that surgery is needed for this patient?
So it is sir, gradually increasing size, sir. It can be due to.
Is it a communicating or a close?
What do you mean by communicating cyst, Dr. Nikunj?
Sir, it is communicating with the calysis or sir, pelvis, sir.
So during surgery, is there any way you can identify whether it is a communicating one or not a communicating one? You said you aspirated. Am I getting it right? You
Yes, sir.
aspirated.
Sir,
So what was the character of the fluid which you aspirated?
sir, straw color was the fluid color.
Okay. With the fluid removed, can you do some simple test to identify whether there is a
Yes, sir.
system communication or not?
Sir, fluid create and urea, sir.
Okay. So, sir, please ask, sir. Sorry. Muteshwarai, sir. We wanted to ask, sir.
That's why, sir. Is there any like a role of any contrast injection to know the communication to the pelvic calcium system?
Sir, DTPS cancer.
Sir, I would say the candidate, if they are telling they are doing a renal protocol CT, and then they have established late non-enhancement into the cyst, they can justify things, sir.
Okay.
I'm sure it is preferable. Sir, many centers don't have the intraoperative CM imaging where they can be attempted. But the point is, sir, I'm not sure whether they've removed the entire cavity. Partial nephrectomy, I mean, you gave, how much of margin you gave, Dr. Nikunj? All around?
Sir, 1 centimeter.
Then why do you call it as partial nephrectomy? This is nephron sparing surgery. That is all. Partial is you should remove at least 50%. Na?
Yes.
So technically, you have hardly any major kidney tissue. So this will be a nephron sparing cyst excision.
That's
Yes.
All right. Okay,
Yes.
done. So how do you assess that you have removed the cyst incomplete? With that little bit of nephron parenchyma which you removed,
Yes.
how did you control the hemostasis of the resected end? Is there any maneuvers you employ in your department to minimize the bleeding?
Sir, sutures were
Before applying sutures?
no, sir. Cold.
You don't use ice cubes, cold ischemia?
No, sir. We haven't used.
Okay, it is always preferable
Yes,
to have a vascular control beforehand doing anything like this, because even you do a nephron sparing surgery, people end up bleeding profusely. Once it starts bleeding, the retroperitoneal fat becomes a mess for you to locate the bleeding vessel. So any tumor surgery, first before even mobilizing, you go to the feeding vessels. Beforehand, your CT radiologist will help you to understand whether it is a single vessel or multiple branches. And most of the time, they'll be able to also tell which branch is supplying the pathological area. So that will give you a roadmap, how much of nephrons you can spare. Most of the time, that will guide you how much of vessels you have to hook around before planning to do something for this. All right. And did you place a drain after this operation?
Yes, sir.
So how long and what was the drain output in the first 2-3 days, and how many days did you keep the drain?
The patient is still admitted. Today is sir post-operative day 2. So for first day 50 cc serosanguinous discharge has come, and sir today sir till now sir 20 cc serosanguinous discharge has come.
Okay, what is the color of the urethral Foley drainage?
Sir, it is sir with slight blood tinge. Sir, it is on first day. There was 2,000 cc of sir urine with a slight blood tinge. And sir,
what
today
was the difficulty in placing a catheter in this patient? Did you find any difficulty?
No, sir.
So was a cystoscopy done at all?
No, sir.
Your patient had the CT, there was a medial lobe eminence is prominent, impinging on the urethra. It has any impact?
What's it?
Ideally, Dr. Nikunj, if you have seen all the faculty here, Dr. Amit sir and Muteshwar sir pointed out, the bladder wall looks thickened and you feel there is some element of obstructive uropathy. It is prudent we do a pre-procedural cystoscopy. In our department, we follow that routine. So every department has this. Yes, madam.
Nothing, sir. Nothing.
Somebody else is speaking. Okay. So the policy should be to do a cystoscopy prior. I'm sorry. So that helps you to understand pre-procedurally whether you need to do something. Many times, if there is enhancement, vascular or a like diuretic phase of CT scan, you can also do a stenting if there is a necessity. And then what did you do for the PU junction stones?
Sir, we have removed.
And obviously means you have opened up the pelvis then.
Yes, sir.
How did you close them?
You said you got only 1 centimeter margin.
Pelvis is somewhere medial, no, Nikunj.
Yes, sir.
So you purposefully opened the pelvis?
Yes, sir.
How did you palpate? How did you locate the stone? You were able to feel the stone.
6
Yes,
millimeter
sir.
stone.
Very difficult, Nikunj, for 6 millimeter stone.
1 centimeter.
Sorry, sir. Please, sir. Muthendra, sir.
Sir, he told 1 centimeter of stone, sir, with mild nephrosis. I don't know.
8 into 6 millimeter.
Sir, 6 millimeter.
Oh, then no need of these things, right? 6 mm, I think it's not.
Sir, first of all, opening the pelvis will be a challenge. And,
Yes, sir.
for this reason, opening the pelvis is definitely a little morbid, sir. That is all. Okay, don't worry. You have any questions to be clarified with the faculty here?
What is the histopathology?
Sir, only 2 days in surgery, sir.
It is awaited, sir.
Oh, wait. Okay.
You have any suspicion on that? What do you expect the histopathology to be?
With intraoperative findings now, is there the cystic?
Sir, simple renal cyst, sir.
Okay. So quickly tell
Just
what
an aspiration would have been useful for that. Instead of doing to that level you are saying a transparent surgery. Because you said it is a stroke alert. That means it doesn't look like much a communicating one.
Okay. See, now you have so many things for you to read up. You please go back to Bosnia classification of cyst, and then Bosnia classification based indication for intervention for the cyst. Many times it is image guided intervention alone. Either cystoscopic or ureteroscopic intervention is possible. Now, endourology is become surgery, little redundant. Here, you can boldly say, sir, considering the size and considering the lump patient is being feeling, I wanted to relieve the symptom. Now, only question is you have to defend whether you need to operate or you do radiological guided procedure. All right. And then you have to definitely discuss with your radiologist regarding the content prior. Depending on the content and the characteristic of the intracystic contents, your decision will vary. I wish you go back to reading Campbell Urology. Campbell Urology, there is a chapter on renal cyst. I wish you study that. You will definitely get a lot of information. All right.
Yes.
And faculty, do we need to ask more questions or can we move to the next case? Sir?
To the next.
Can move to the next one.
Next case.
Nikunj, do you have any doubts to be clarified?
No, sir. Thank you, sir.
Thank you, Nikunj. Modi sir is here. He has joined. Sir has joined. No.
Nikunj, don't feel bad, and it's only you are in the second year or the final year?
The second year, sir.
So systematically follow the studies. Putting in the hard work, definitely you have a lot of basic knowledges. So if you put it in a coherent way, you can do much better.
Yes.
So be cheerful and go ahead and, as Kanagvel sir has said, read Campbell, and you will be more confident.
First of all, I recommend you to read DAS once again, because palatability, renal angle, all those fundamentals, no. Once you get stuck in the exam, see, in this teaching model, we allow 1 hour. So you have all the breathing time to justify your knowledge. But in exam, when clinical examination, when these questions are not relevantly answered, the examiners might definitely take their exceptions in taking you further. All right. So renal angle, why renal angle is resonant? What is the structure which makes it resonant? And then palatability, bimanual palpability, movement with the respiration, you can justify. The mere size of it could be directly or indirectly in touch with the diaphragm, so it can still be mobile. right? But then you should have very strong justification when there is an unusual finding in your patient. All right. So I wish you go back to DAS once again, examination of renal mass chapter. And then the next one is the Norman Browse or the Hamilton Bailey is also much useful. All right. So with that, then you go to Campbell. Straight away, don't need to go to the Campbell. First, clinical examination is the most important for your MS examination. Once you successfully cross the clinical examination, then comes all the management. But this will be a exam case or exam short note or long note question, definitely. All right.
Yes.
Good luck.
Thank you, sir.
Okay,
Back
thanks.
Dr. Ashish, are you with us? Nikunj, you can unshare the screen, ma,
Yes.
and you can stay with us for the next case discussion.
Yes, sir.
Ashish,
Yes, sir.
you switch on your video. Your system is all right, ma?
Yes.
Okay, you switch on your video. Nikunj, I request you to unshare the screen.
So thanks.
Ashish is there. Okay, Ashish.
Yes, sir.
Okay,
Sure.
please share your PPT, ma. Yes, make it full screen. Please introduce your head of the unit, head of the department, and start your presentation. Good luck to you.
Good evening, all the faculty members. Myself, Dr. Ashish, third year PG of Department of Surgery, AIMS Rishikesh, and my moderated Professor Amit Gupta, sir, Department of Surgery, AIMS Rishikesh. So my patient, 79-year-old lady, resident of Ukimat, Uttarakhand. She is a homemaker. She presented to us with chief complaints of ileous discoloration of eyes for last 30 days and ileous discoloration of urine for last 30 days and itching over the whole body for last 20 days. Apparently she was all right 30 days back when her family members noticed ileous discoloration of her eyes and which was gradually progressing, and there was no waxing and waning pattern. And the ileous discoloration of urine also was she noticed 30 days back. And there was a shared history of passage of pale color stool and generalized itching over the whole body for last 20 days. There was history of loss of appetite and unintentional weight loss, which she described as loosening of clothes. There was no history of any pain abdomen, vomiting, melena, no prodromal symptoms like fever, melee, generalized weakness, no arthralgias, no history of abdominal distension, no history of altered bowel habits, no decreased urine output or altered sensorium, or no history of any hemoptysis, seizures, or backaches. She's a known hypertensive for last 3 years under medication, no other comorbidities, no previous history of any jaundice or pain abdomen, and no history of any blood transfusion in the past, no history of any chronic drug intake, and no history of any surgery in the past. She takes mixed diet, no addiction, and her sleep was disturbed due to generalized itching. She is a P9 LA, menopause for last 29 years. And in her family, there is no history of any jaundice in the family, and no history of any malignancy or malignancy-related deaths in the family. Summarizing my history, an elderly lady with painless progressive jaundice for last 30 days with generalized itching and passage of pale color stool, ileous discoloration of urine with loss of appetite and weight with no prodromal symptoms with hypertension as comorbid.
Go back to your first slide. Sneha ma'am, you can take up, ma'am.
Yes, sure. So according to these chief clinical examiner complaints, what are your differential diagnoses at this particular point in time? What are you thinking? Whether it is a medical jaundice or a surgical jaundice?
After taking history, ma'am, my first diagnosis will be it's the surgical jaundice.
Why are you saying it is a surgical jaundice?
Ma'am, the patient is has a progressive jaundice, also has no history of any prodromal symptoms like fever, melee, and also she complains of passes of clay color stool. And
So the
yellow
term you
disturbed-
have used is pale colored stool. The
Yes,
term
ma'am,
is
pale-
clay colored stool. It is not
Ma'am,
pale colored stool.
yes, ma'am.
Okay. Carry on.
So my diagnosis will be a obstructive jaundice, surgical jaundice.
Surgical obstructive jaundice.
Yes,
Okay.
ma'am.
Okay. Then come to the next slide. All right. So what do you mean by waxing and waning pattern of jaundice?
I'm waxing and waning pattern in where the jaundice lessens a bit, but not it's not like gone. It's lessens a bit, and again it starts rising. So there is
What
a
are the conditions you will find these type of pattern of jaundice?
benign conditions like choledocholitis, like any fluke infestation, fluke in the this one, and in malignant conditions, ma'am, periampullary tumors, and in papillary variety of cholangiocarcinomas.
So why do you think in periampullary carcinoma this phenomenon occurs?
Ma'am, in periampullary carcinoma, the tumor size gradually increases, and then the central part lacks the blood supply due to unproportional growth, and then the central part get necrosed and it sloughs off, and then causes the bleeding, and that comes as a malignant.
Any other history the patient will give along with the decrease in the jaundice?
Ma'am, passage of black tarry stool.
Black tarry stool. Right. Okay.
Your patient is only 30 days duration of the history. Do you expect this waxing and waning?
No, sir. 30 days. No, sir.
What is a normal waxing and waning window?
Sorry, sir.
What is a normal waxing and waning window? How long the tumor need to grow to get a wane?
Sir, 2 centimeters, sir.
No. Duration.
Duration.
Sir, 2 months.
2 months. How exactly that happens? It overgrows the vascularity, right?
Yes, sir, overgrows the vascularity.
So for it to overgrow the vascularity, it necros, and again the tumor to grow. Is there a time window?
What is the half-life of bilirubin?
Sir, 21 days.
So that also your time has to be counted. No? The existing bilirubin will be the value. Right?
Yes, sir.
So a minimum of 3 to 4 months existence is mandatory to apply these statements, right?
Yes.
So you can, when madam is asking about the differentials, so this can be very carefully excluded. Later, if the examiner asks you why not periam, then you can justify because of the shorter duration. I wish I will not consider this.
The history you are saying it is a gradually progressive. How do you know it is gradually progressive?
Sir, the patient is telling the deepening of jaundice, sir.
What do you mean by that word, deepening of jaundice?
The first, the patient gave history. At first, it was just yellow, sir, and then now it's becoming green, oranges, sir, then greenish, then now brown.
No. Is it the site, different sites of the body? It affect the jaundice? Do you say that progressive jaundice, or only the color?
Sir, also the site of involvement, so like sclera, then undersurface tongue, then when it's more than 14 and
The color of the bilirubin, what will be the color of the biliverdin?
Sir, bilirubin will be, sir, greenish, sir.
Biliverdin?
And biliverdin will be, sir, brownish.
Which one? You said 30 days urine and ice. It's the same time it has happened?
Yes, sir. The patients are said, sir, 30 days.
Normally, what do you expect? Yellowish discoloration of the eye you see first, or the urine you see first?
Sir, eyes will see first.
Oh, then what is the hyperbilirubinemia and jaundice?
Hyperbilirubinemia, sir, when more than normal range, 1.
Bilirubin level can be high, still the eyes need not be an yellowish color.
Yellow, sir.
So, but the urine not like that. The bilirubin, when it comes, the urine will be yellowish in color. The first thing is,
Can you name some medical causes of jaundice?
Sir, infectious causes, sir, like hepatitis B, hepatitis C, hepatitis E, sir, and different sir, drug-induced hepatitis, sir, like ATT-induced, sir. Then cholestatic jaundice. Then, sir, autoimmune hepatitis.
So which bilirubin will rise first in hepatitis? Which part of bilirubin will rise first in hepatitis?
Unconjugated.
Unconjugated. So what is the rate limiting step in bilirubin metabolism? Which gets first affected?
Sir, the conjugation of the bilirubin.
No, it is the excretion of conjugated bilirubin into the biliary canaliculi. So the conjugated bilirubin rises first. Have you heard of autoimmune hepatitis?
Yes, sir.
Okay. And have you heard of autoimmune cholangitis?
Yes, sir.
So autoimmune cholangitis will have also deepening jaundice as well as altered color of stool or clay colored stool. Patient will have similar presentation than obstructive jaundice. So how will you differentiate?
Sir, in autoimmune hepatitis, patient will have features of fever, sir, then rashes, and also sir, obstructive patterns also will be like ALP and GET, sir.
No, please understand the question is very clear. Is there a clinical way to differentiate autoimmune from other hepatitis? If not, is there any lab investigation which can help you to identify? These are the
Sir, liver, kidney, mitochondrial that antibody, sir, and LKM1, sir, then antimicrotomal antibodies, sir. All these will be positive in autoimmune hepatitis.
Is there any drug therapy which can help you to understand whether it is autoimmune or not?
Sir, if you start immunosuppressant, like then it will help in autoimmune hepatitis.
Sometimes it is by exclusion. Rarely, if nothing is conclusive, then you go for a need biopsy. I think we'll discuss those things. Man, Vaibhav sir, you take over, sir.
Yeah, sir. Please continue. You continue.
Kanna sir, do you have any questions, sir? Neha ma'am?
Sir, I think we should go to the next slide first.
Please. Go to the next slide, ma'am.
Okay.
You were repeatedly saying no prodromal syndrome. Now suddenly you are saying loss of appetite. What is the difference on that?
The loss of appetite.
And what is the prodromal symptoms you asked, and what is the loss of appetite you are meaning?
The prodromal symptoms, yeah, sir, fever, any malaise, then any arthralgia, rashes.
Appetite will be normal.
Appetite will be reduced, organ of jaundice.
No, that. How do you come to this conclusion? History of present no prodromal syndrome, loss of appetite. What is the purpose of asking that question?
Sir, loss of appetite, sir.
No, prodromal syndrome and loss of appetite.
So prodromal symptoms we ask, sir, to differentiate between medical jaundice and if the cause is medical jaundice or
like hepatitis.
Yes, sir. Hepatitis.
Viral hepatitis.
It is. See, Dr. Ashish, prodromal symptom is what are the symptoms which is prior to the actual disease condition.
Yes.
once hepatitis sets in, then you get persistence of symptoms. I
Yes.
wish to go back to Harrison as well as Schlesinger's the preliminary 4 chapters, which very clearly differentiate between these two. Okay, I will ask one simple question. What are prodromal symptoms of hepatitis? What are the symptoms of hepatitis?
The prodromal symptoms, fever, malaise, arthralgia, sir, rashes, and hepatitis symptoms are, sir, patient will have vomiting, sir, then pain at the right upper abdomen could be there, sir. They might have diarrhea also, and then signs of liver fulminant, if fulminant disease is there, sir, signs of liver failure also will be there, sir.
Very simple. Though you are getting confused with both. Prodromal symptoms may not be directly persistent to the liver cell failures. So you tell there is a hepatocyte dysfunction, then what all happens becomes a true symptoms. Till then, any GI infection or anything can present with all those things you tell. All right. Generally, it's very tricky. Unless you ask, patient is very knowledgeable, you will be able to differentiate between these two. All right.
Okay.
So most of the time, malarial illness or the hepatitis A type or the E type, these are the ones which may have prodromal symptoms. But again, in our discussion, they are very unlikely. Maybe Dr. Vaibhav sir, I think you do see more liver than any one of us. Maybe you and Sneha ma'am can highlight us the difference more.
See, actually, in hepatitis, actually, we see patients in very late presentations. So we see patients when they took, when they are having end stage problem. So the initial part is taken care by the physicians. But yeah, patients, they, I lost you. Where
The point is the prodromal and the real symptoms of hepatitis. So I wish if the candidate tells a non-specific GI symptoms can be attributed to prodromal, and when there is a typical presentation of jaundice, true food intolerance, stool color change, when those things come in, we call it as hepatitis symptoms. Will that be acceptable to you, sir?
Yeah.
Yes, sir.
Yes.
And you were saying also significant weight loss with 30 days.
So this patient can have malaise, patient can have easy fatigability or generalized weakness as prodromal symptom when patient is having some liver cell problem, as you seen in hepatitis, right?
Yes.
Yeah.
Why the urine is yellow in jaundice patient?
In obstructive jaundice patients, the conjugated bilirubin also will be in the blood circulation, sir, and because of the bilirubin only, it will be yellow, sir.
It's because of conjugated bilirubin.
Yes, sir.
Right. Now, what is the maximum bilirubin which can be reached in a case of obstructive jaundice? Usually
40 to 45, sir.
Why does it stop at that point? Why the plateau is there?
Sir, after this point, sir, the biliary pressure raises till 30 centimeter of H2, sir. At that point, sir, the secretion stops, and also because of the hydrostatic pressure, sir, the more secretion the canaliculi stops, sir. So further increase is not.
And what will happen to the stool in these patients at that point?
So they might have a yellow color stool, sir, because of jejunal secretion of.
So the pale color stool which is there, or the clay color stool which is there, is becoming the yellow now because of exfoliation from the jejunum segment.
Yes.
Right. Now tell the condition where you will find that eyes are yellow, but urine is not yellow.
Sir, acholoric jaundice, sir.
Good. And what is the cause of acholoric jaundice?
Sir, prehepatic jaundice, hemolysis.
So Can you tell few conditions where the patient can have this condition?
Sir, hemolytic jaundice, sir.
Yes.
Then
The patient is given the blood transfusion, what will
blood
happen?
transfusion reaction. Yes, sir. Blood transfusion reaction. Acute blood.
Okay.
You move on, Dr. Ashish. Candidate, faculty, you can ask any questions in this slide. Neha, ma'am?
Yes. So what are the causes of abdominal distension you are thinking in this patient? You have asked that there is no history of any abdominal distension. What can be associated with jaundice and abdominal distension?
In advanced diseases, ma'am, because of gastric outlet obstruction or duodenal obstruction, the patient can have a the abdominal distension. Other than that, because of ascitic, malignant ascites, patient can have abdominal distension.
Gastric outlet, you get abdominal distension or stomach is distended?
Distended stomach, sir.
The patient will present with vomiting rather than more with the abdominal distension.
Yes, yes, ma'am.
Okay, in this patient, what like it told no history of altered bowel habits. So what exactly you want to know? What do you ask exactly? Is it steatorrhea type or any other constipation or something? What do you want to ask in the jaundice patient?
So jaundice patients, sir, I wanted to confirm whether in some jaundice due to some colorectal malignancies metastasizing to the liver. So I just wanted to rule out any altered bowel habits for that.
Okay.
Okay.
Next slide. What will be the color of melena in obstructive jaundice patients?
Silver color, sir.
Why?
So because of clay color stool will be like aluminum paint, and melena also will mix with that and form silvers.
Why melena? Why from the blood is coming from where?
Obstructive jaundice, sir.
Yes.
From if some growth in the periampule region is sloughed off, then the bleeding will occur from there, sir. Upper GI.
Can portal hypertension coexist with the obstructive jaundice?
Sir, sorry, sir.
Can there be a coexistent portal hypertension in obstructive jaundice?
Can be.
Okay, I think they are too complex for you at this stage. Faculty, please take him over.
Yeah. In past medical history.
Yeah, so just taking the same. Yeah. Yep,
Yes, sir.
please continue.
Yeah,
No, please, sir, continue.
Yeah,
actually, just taking forward the Dr. Kanagvil's question, he's asked you that can there be portal hypertension in a case of obstructive jaundice, right? So forget about the cause. Cause can be anything. What can be the possible causes of portal hypertension in a case of obstructive jaundice?
Sir, any malignant growth causing the involving the portal vein, sir, can cause head of pancreas.
You think other way. Your axis of thinking is not appropriate. You have to think other way.
Or maybe, sir, some thrombus in the
Intrahepatic or extrahepatic?
Extrahepatic, sir.
No, we are talking about portal hypertension. To have a portal hypertension to set in, how it takes much longer time, no, clinically.
Right.
To have features of portal hypertension to develop, they don't just like that develop over the day.
Sir, a cirrhosis patient having a hepatocellular carcinoma.
Yeah, that is very simple. Existing cirrhosis patient. Agreed. Otherwise, If there is only left-sided portal hypertension,
No.
So what finding you will have if there is only left-sided or sinistral portal hypertension? So you can see splenomegaly, right?
Splenomegaly.
With or without ascites.
so if there is a question when the examiner is asking, so you can ask the examiner, sir, are we talking about the regular portal hypertension or the left-sided portal hypertension? Or you can answer right away. Whenever you are talking about hepatobiliary, especially we are narrowing down to pancreas, you talk about the left-sided portal hypertension first. Left-sided portal hypertension can be, here you definitely have excluded chronic pancreatitis as a background. So that way you can tell, sir, there is no history of recurrent attacks of pain or acute attack of pancreatitis or acute attack of pain in the upper abdomen like that. So you can justify that way. But then when the question is asked in your theory exams also, coexistent portal hypertension and malignancy, then you have to justify either it's a left-sided one or a conventional portal hypertension. All right.
Okay.
Faculty, please take over. Vaibhav, sir.
Yeah, you have written no other comorbidities. So will you like to ask anything specific about new onset diabetes?
Yes, sir.
Why?
New onset diabetes, sir, in many pancreatic malignancy patients, sir, they present with new onset diabetes, sir. And also, diabetes also risk factor for pancreatitis itself.
That's good. So new onset diabetes can be a presenting symptom of pancreatic cancer. Anything else you will like to ask in past history? Significant?
Sir, regarding sir comorbidity, sir.
Yes. Related to pancreas?
Sir, chronic pancreatitis was there. I'll ask recurrent attacks of pain is there or not? Because chronic pancreatitis itself a risk factor for pancreatic adenocarcinoma.
Yes.
Can we move on, sir? We'll move on to the clinical findings, sir.
Yes.
Okay. With this, we have a very short duration of jaundice, right? With
Yes.
definitely little bit of weight loss, which at this point, would you like to offer one working diagnosis or you want to offer more than one working diagnosis?
Sir, more than one, sir.
What are they? What should be a first priority?
See a head of pancreas, sir.
Okay.
Second, sir, periampullary tumor.
Why periam? We discussed so much about waxing, waning, and still you want to stick out to periam?
Sir, the duration is 1 month, so.
So whether the head of the pancreas is also a part of the periampullary carcinoma?
Sir, the middlemost part of the head, sir, like 2 centimeter, within 2 centimeter of ampulla of head.
What made the history? What made you to think it could be a possibility of a pancreatic? I mean, pancreatic head.
Sir, the age of the patient, sir, and also the gradual progression, the short duration of history, and there was no history of any malign and waxing waning as she mentioned, but duration is very less to go to that conclusion, sir. But still, my diagnosis, because of that only, I made a diagnosis see head of pancreas.
But you are saying there is no complaint of any pain abdomen. Mostly pancreatic carcinomas have pain abdomen.
Ma'am, pancreatic early pancreatic carcinomas they might, because late stage is only there.
We are coming to the diagnosis. History wise, what is your probable diagnosis?
Yes,
Okay.
sir. History wise,
Can
I
it be
need to
common
do
violet stone?
CVD stone, sir. Sir, no, sir. There is no history of any pain, sir, in the past. Patient never given history of any past pain, sir. And no history of any pain in recent days also.
Faculty, can we move on to the clinical findings?
Yes.
Yeah, please go ahead.
Yeah, sure.
Yeah.
Actually, just a food for thought. Can at this point of time in history, before jumping on to the clinical examination, can you put another
Sorry, sir.
Can you put hilar cholangiocarcinoma as one of the differential based on the history alone?
Based on the history alone, sir, I can put hilar cholangiocarcinoma.
Yes.
A more safer option, sir. Amit sir, will it be okay if he talks about the common bile duct tumors or cholangiocarcinoma locating at this point, sir? Because at the end of clinical finding, if he is able to locate, maybe bile duct tumors will be have to be a one safe consideration. What is your take, sir, as a faculty? What
Yeah,
you want to make?
completely, sir. Agree.
So cholangiocarcinoma have also to be taken into consideration. So it is better you tell according to the probability of commonality, which comes more common, which comes second common, third common. That way also you should be prepared to take questions. All right. So I think with this, sir, can we ask him to go ahead with the the clinical finding?
Yes.
Vaibhav sir, can we?
Yes.
Ma'am, would you like to add anything? Mutesh Rai sir?
Yes, sure. Yes. No. We'll go with examination.
Please go ahead.
The patient was examined in broad daylight in presence of a chaperone. The patient was conscious oriented and cooperative, average build and moderately nourished, weight of 48 kg, height of 158 centimeter, BMI of 20.6 kg per meter square, ECOG of 1. Patient was icteric. Failure could not be commented upon. There was no peripheral lymphadenopathy. Scratch marks present over the body, abdomen and all exposed parts. No bilateral pitting edema were there, and no signs of chronic liver disease were there. On vitals, her pulse rate was 76 beats per minute, regular on right radial artery, good volume, no radioradial or radiofemoral delay, blood pressure of 110 by 70 millimeter Hg in a supine position right arm, and her saturation of 98% room air, and respiratory rate was 18 breaths per minute, and temperature was 98.6 degrees Fahrenheit. Moving to a periodontal examination.
Your pulse rate has any significance on your diagnosis?
Yes, sir. In obstructive jaundice, sir, we usually see, sir, relative bradycardia, sir.
Why so?
The reason behind that?
Because in obstructive jaundice, the bile salts will go and deposit in the acid node, sir, and the
delay in the contraction.
Contraction, sir, and also contraction.
Heart rate is 120 and temperature is 104.
What will be the possibility you think?
So cholangitis.
Cholangitis. What is the average build you mentioned?
Sorry, sir.
You put as an average build. What do you mean by that?
BMI 20 is thin built only. What is the question of average? What you had something in mind when you put average build or what?
So the patient's stature was like average, sir.
I mean normal. You tell normal or thin build or overweight or obese, right?
Okay, sir.
So what is your BMI score? Where do you want to put a kg square? Meter square, where do you want to put that?
So not required.
It is an absolute number. If you mark, it is accepted.
Yes.
Right. Please.
Some of the textbooks say that, but it is better not to use that, because where we say it's not per kg, we are not talking. It's not missing.
On inspection, abdomen was distended, all quadrants moving correspondingly to respiration, bilateral flanks were appears normal, umbilicus central and inverted, scratch marks were present, no dilated veins or nodules, no visible peristalsis or pulsation was seen, hernial orifices, no visible cough impulse was present. On inspection of the back and spine, it was unremarkable.
Abdomen is distended, but flanks are free.
Sir, distended because she has a fatty abdomen, sir.
No localized.
Okay, go ahead.
On palpation, no local rise of temperature, no tenderness, a well-defined globular lump of 5 × 4 centimeter, palpable over right hypochondrium, smooth surface, firm consistency, moves up and down with respiration. Liver and spleen not palpable, hernial orifice are intact, no spinal deformity, paraspinal tenderness. And on percussion, liver span 13 centimeter in mid-clavicular line, dullness over the lump present, continuous with the liver dullness, and there are no shifting dullness present. On auscultation, normal bowel sounds are heard. On palpation of left supraclavicular fossa, there are no lymphadenopathy present. And the examination of the other systems were unremarkable. On DRE, the pale color stools were present, but otherwise no unremarkable. And PV examination also was unremarkable. Summarizing my history and examination, an elderly lady with painless progressive jaundice for last 1 month, associated with generalized itching, passage of pale color stool, yellowish discoloration of urine, and loss of appetite and weight. And on examination, icteric with palpable gallbladder and hepatomegaly with hypertension as a comorbidity.
So you mentioned that liver is not palpable.
Liver span is only 13 centimeter.
And you're saying hepatomegaly?
So 9 to 12 centimeter in mid-clavicular line. Span of liver. So
Yeah, I will like to interrupt here, Ashish. Actually, there is a difference when you say that organ is palpable and organ is enlarged, right? There may be conditions when liver may be enlarged, but you are not able to palpate when you especially see in obese patient individuals, right?
Yes.
And vice versa may be true in some conditions, right?
Yes, sir.
Synoptosis can be also there. Girdle sign can be.
See, when we are talking about 20 BMI, we exclude many things. All right. So,
Yes, sir. Yes.
Like it is better you tell with the liver span, right?
Yes.
Or I would say if you want to quantify, you can justify it is a soft hepatomegaly, firm hepatomegaly, or a nodular hepatomegaly. That will add weightage to you so that the examiners will accept towards certain diagnosis.
What could be the reason for this hepatomegaly? If you are suspecting still there is hepatomegaly.
Sir, in obstructive jaundice, sir, because of back pressure, the hepatosis will be there, sir. Because of that, liver will enlarge.
There is a loss of appetite, reduction of the weight. Does it have any value?
Sorry, sir.
No, your patient has significant loss of weight, you said, and
yes,
appetite is also very poor. That means he is not taking food.
Sir.
And malnutrition produce hepatomegaly?
Can sir.
These patients, even though they present you with 30 days, it should have been much longer. The jaundice most of the time, one of the family member or when they are watching in the mirror or something only they pick up, or unless there is a color of urine change and stool color change alerts them. So it definitely is much more than the 30 days history when the patient tells. So you can ask little more if depending on the knowledge level and the educational background of the patient, they may give you much more detail. All right. So with this, what are the potential things you have excluded? Or you want to give a single diagnosis, or you want to give more than one diagnosis with the after the clinical examination?
Sir, with differential, sir, my first
like that.
First provisional diagnosis will be, sir, carcinoma head of pancreas, sir. And differential, sir, Klatskin tumor. Then next probably periampullary carcinoma.
But in Klatskin, the gallbladder is palpable. How it's saying that is a Klatskin tumor?
I mean, case of Klatskin tumor, it might involve the cystic duct and CBD junction, CHD junction.
So it is better if you say distal cholangio rather than a Klatskin tumor if you have a palpable gallbladder.
Okay.
Exclusions, rarities can be when the examiner asks. So my choice will be to have a carcinoma head of pancreas is definitely fine. Distal cholangiocarcinoma probably later will be the periampullary carcinoma. Other carcinoma can be told little later.
So in how many patients of, sorry, sir, in periampullary carcinoma, how many patients you will find this waxing and waning? How much percentage?
40 to 60% patients.
30 to 40% of the patients. So, and this short duration of history, it should also come above. If I were at your place for a painless progressive jaundice, I'd keep periampullary first as a diagnosis. Then I'll place a distal cholangio as second. Then thirdly, maybe I'll place a CA head of pancreas as the third differential.
Agreed, ma'am. Agreed. I think that's right. Vaibhav sir, would you like to add up something?
No, I think no.
Mutishwarai sir?
But for the classical tumor, that is not acceptable. When you're saying this is 20.
Any benign lesion you want to keep at this point of time? Any benign lesions you want to keep?
At this point, seeing the
respiration rate manually,
the progression of the jaundice, ma'am, and age of the patient, no benign lesion I can.
Okay, agree.
What are the causes of jaundice in a case of carcinoma gallbladder?
Sir, if see a gallbladder involving the neck of the from the neck of the GV, sir, involving the CVD, sir, it can cause obstructive jaundice, sir. Next, sir, due to lymphadenopathy, retroportal or pericortical lymphadenopathy, sir, they will cause extraluminal compression, sir, and cause obstructive jaundice. Then, sir, any metastasis to the caudate lobe, sir, they can cause obstruction and cause the jaundice.
Mm-hmm.
Why only caudate lobe?
Because for any metastasis in the liver, it should be a large metastasis which can cause a obstructive jaundice.
You want to say that if there's solitary metastasis in the liver is there,
solitary metastasis
be responsible for the jaundice is the metastasis to the caudate lobe. Okay.
Caudate lobe. Yes.
Right. Can stone be there with the cause for that?
Yes, sir. Stones can.
What is the chance of having a CBD stone in a case of CA gallbladder?
Sorry. I'm not sure.
Will the stone be the reason for the carcinoma?
Yes, sir. Stone is a cause of risk factor for CAG.
Do you get the GB stones in the patient with the CA gallbladder?
Yes, sir, we get
10%, 20%, 30%, 70%.
90% of the patient.
About 70 to 80% will have the GB stones. And 10% can have the CVD stones. So one of the causes for that can also be the CVD stone also. Jaundice in the patient with carcinoma gallbladder.
Sir, I would like to interrupt here. Answering to Dr. Khanna's question, I think different series across world and across India have reported different incidence of stones in patients of gallbladder carcinoma. So in our series of around 1,000 patients, what we have observed is that the incidence of gallbladder stone in our institution is very low. It's not as high as some other series have reported. So it's close to only 45-46%, sir.
Yeah, it varies from 50 to 70%, you know.
Yes, sir. Yes, sir.
So 50 to 70%.
So one very large series which is published by Professor V.K. Kapoor from SGPGI, he also has reported to the tune of around 65%.
Yeah.
Yes, Ashish, you can carry on.
Ashish, for the sake of convenience, okay, fine. You have imaging also, right? Can you show the image so that the examiners can give you a working diagnosis and take it further?
Sir, actually the CT is of outside. Outside was done, sir. It was not.
No problem. With this, you read the CT.
In CT, sir, the liver was 14 centimeter in size with smooth homogeneous parenchymal attenuation. No solid and cystic mass seen. High HBID was present, and GB was grossly distended, smooth outline with normal wall thickness. CBD dilated and measures 18 mm.
IHBRD?
So intrahepatic radical dilation.
What I'm asking, in this image, you get to see IHBRD at all.
Sir, central IHBRD was there, sir, in the other cuts.
Because that makes you so many differentials get excluded when you talk about only central or the entire liver parenchyma. All right. So when you talk about IHBRD, you also mention the character of the IHBRD. Obviously, you should have had more slices to comment about it. But it looks like the parenchyma at least do not have much of dilatation, whereas the central IHBRD can be commented upon. Because that excludes two things. One, the duration. The second is the completeness of the obstruction.
Yes.
Right? These are the two important information you get when you are talking about central and peripheral IHBRDs.
Yes.
And it also tells about the probable cause. Move on to the next part. You're told about the liver, then
CVD is dilated,
18 mm.
measures 18 mm and appears obstructed at the lower end. And pancreas, there is irregular small enhancing mass seen in the pancreatic head. They are not sure, sir. It's head or employee. They gave it like that only. Measuring 2.5 cross 2 cross 2.7 centimeter. And pancreatic duct dilated 5 mm in diameter. No vascular involvement.
What are the potential?
So they said that.
Yes, ma'am. Please go ahead.
Sorry. So they said there's an enhancing mass in the pancreas. The CA pancreas, they are hypotense lesions. So the enhancing mass, first of all, you make sure the CT report is right.
Actually, the CT was, they got it done from a private practitioner before coming to us. So it was the protocol and all, it was nothing was written on there. So one Excel film was there, from that only took 2-3 pictures, that also not corresponding.
Okay.
Can you comment little about the pancreatic parenchyma in these slices what you have?
Sir, the pancreatic parenchyma, sir, the duct looks dilated, sir. And the parenchyma is a little atrophied.
Because it looks scarred.
Yes, sir.
It doesn't look like there is some definite element of chronic pancreatitis element here. And
Yes,
the dilatation is also not looking uniform. Maybe yes, here, Vaibhav sir, Kanna sir, what is your take on this CT, sir?
Yeah, it looks like atrophic pancreatitis. I mean, atrophic pancreas. Duct is dilated. How will you like to assess this CT in relation to vessels?
Yes, sir. We would like to, sir. That is.
What will you like to see?
Sir, in CT, sir, I'd like to see the relationship with the portal vein, SMB and SMA, sir.
So what it will let you know?
So the resectability and borderline, and or is it unresectable?
Is there any biochemical marker which can tell you about further about this tumor?
The CA19-9, sir.
What it is and what it will let you know?
These are carbohydrate antigen 99, sir. That in case of CA pancreas, sir, it will be raised, sir. If it's a metastatic disease, sir, it will be more than 1,000, sir.
So your patient is having hyperbilirubinemia. So will you?
Cholangitis also it will be raised, sir.
Okay. That's good. Will you like to investigate this patient further before subjecting him to,
yes, sir.
patient to definitive management?
Yes, sir.
In what form you will investigate further?
First, sir, we'll get a CT pancreatic protocol from our institute, sir. Before that, I can go for a USG, sir, and other biochemical parameters, sir, relevant to it. Then CT pancreatic protocol. Then once I'm confirmed with my diagnosis and staging of the disease, then I'll preoperatively optimize the patient. The itching, the pain she's not having right now, the itching part, the jaundice infection, the dehydration, nutrition, and the coagulopathy. All these I'll optimize. Then I'll subject the patient.
From this CT scan, you can very well say that this is enhancing lesion. The
Yes,
lesion is well away from vessels. Then why will you go for another CT?
sir. In this city, sir, the lesion that is enhancing, sir, its relation with the because sir, all other phases are not there, so we are not sure.
Okay. Okay. Will you like to investigate him in with any other modality?
Sir,
all the investigations available in your center.
Yeah, with everything available.
sir, if pancreatic protocol, if you do it inconclusive, then you can go.
You
can-
move on from pancreatic protocol CT. Move to the other set of available in investigation.
Sir, MRCP you can do, sir.
Move out of imaging.
Okay, sir. Sir, we can do US, sir.
Yes.
Endoscopic
Yes.
ultrasound.
Endoscopy.
So do you think tissue diagnosis is a must in this patient?
Sir, if pancreatic malignancy, sir, then tissue diagnosis is not doesn't alter the if resectable disease doesn't alter the malignancy.
How accurate or how sensitive the CT is in detecting in making diagnosis of CA head pancreas?
So 90% sensitive, sir, 70% specific
For any size tumor?
for more than 2 centimeters.
Yes. Yes. So suppose if you have less than 2 centimeter size tumor, then will you like to investigate him patient with EUS?
US, sir.
So what is the accuracy of EUS?
So 69%.
69.
Yes, sir.
No, it is more than 90%.
More.
Yes, definitely.
This point of time, Dr. Ashish,
Yes, sir.
and US gives more pickup of common bile duct stones, more pickup of common bile duct lesions and PD lesions than any other investigation. All right.
Yes.
So in exam, I would say 90+% of pickup rate, or I would say sensitivity. Specificity is close to 80%. Again, it varies because this is a user-dependent investigation. That's why multiple center, it varies. All right. But the more so, the most important thing is the access of tissue, right? That is the most important advantage you have. EUS gives you in EUS done is giving, because and it is least traumatic to do the investigations with EUS.
Yes.
So can you quickly tell what is the type of the EUS scope you'll use for imaging and what is the type of EUS scope you use for intervention?
Sir, I'm not sure.
Okay, no problem. You wish you can go back to read little about it. There are little subtle variations between what is used for diagnosis and what is used for interventions. All right. So I think faculty, we can give him a working diagnosis now, and then we can ask him how he'll plan for the procedure. Okay, we will take a call. This remains as a probable pancreatic head tumor with the obstruction to both the common bile duct and to the pancreatic duct. So patient is optimized. Staging gives only a regional disease and not a other. Only thing is we'll keep a. I think we get back to the biochemistry. What was the albumin level?
Ruben is.
Our albumin was 3, sir.
Okay,
What
then
is the significance?
please, sir, please go ahead, sir.
Yeah. What is the significance of albumin level? How it will determine?
Sir, in synthetic function of the liver, sir. So if albumin will also go down in obstructive jaundice, sir. So more than 3.5 is normally
Will it help in risk stratifying your surgery or the management?
Yes, sir. If it's less than chances of postoperative pancreatic lesion.
Your patient is having bilirubin of 27.
27.
So will you like to, have the decrease in bilirubin before subjecting him to definitive treatment?
Sir, if the patient is not in cholangitis, then we can go for surgery, sir, or otherwise you can go for preoperative drainage. But more chance of studies has shown, sir, more chance of infection.
But
Yeah.
the bilirubin level is quite high in this patient. If the bilirubin level is 15 or less, we can go ahead with surgery. At a level of 27, it's too high. The healing of the tissue will be hampered with such a high level of bilirubin.
You can go for endoscopic nasobiliary drainage.
Okay, now suppose the bilirubin has come down, the patient ECOG state. So you said it is 1, albumin is okay, and hemoglobin is also okay. What surgery would like to offer the patient?
As it a pancreatic head tumor, and a resectable, I'll go for a Whipple's procedure.
You will go for
Whipple's.
a Whipple's procedure. Achha. Will you like to preserve the pylorus in this patient, or you will not like to preserve the pylorus?
We can, we should, given the chance, we should preserve them. Pylorus preserving pancreatitis.
What are the advantages of that?
Ma'am, it's a more physiological. So the sphincter pylorus is there. So patient, the gastric, delayed gastric, the most common complication of standard Whipple's, that one will less the incidence, and also bile reflux will be less, then operative time and blood loss during the operation will be less.
Before doing the definitive procedure, will you like to do diagnostic laparoscopy?
Yes, sir.
Why?
Sir, 30% of the cases has been seen thereafter because CT scan might not detect the peritoneal nodules of size less than 0.5 centimeters.
So we like to exclude the liver metastasis. So what is the median survival of resectable pancreatic head cancer?
24 months.
24 months. And how many percentage of patients will present to you as a resectable disease?
10%.
Okay, it's 30%. And then on CT scan, how will you define the resectability? What are the terms being used?
Sir, so resectability, if the SMA or celiac axis is not involved, sir, the tumor is not only in contact, and portal vein and SMV, the tumor only in contact, sir.
So one is resectable. The second is borderline resectable. What do you mean by borderline resectable?
Borderline resectability, sir, the SMA and celiac axis will be less than 180-degree involvement, that is abutment only, and SMV and portal vein will be less than 180-degree or more than 180 without vein contour irregularities, and reconstructible length, and unresectable will be more than 180-degree involvement of SMA and celiac axis, and also the involvement of the in portal vein and SMV, it will be, sir, more than 180-degree involvement with unreconstructible length, sir. And also first SMV draining branch also is involved, or first jejunal draining arterial branch also involved, that also unresectable.
So if a tumor is involving portal vein and SMV, will you consider it as a borderline resectable?
Only if the less than 180-degree abutment is also only this.
Okay, and if it is more than 180 of SMA, it is unresectable.
More than 180 with, sir,
SMA.
Yes, sir, SMA.
Do you think there is any role of chemotherapy?
Sir, studies showing, sir, nowadays gemcitabine based chemotherapies in distant local regional
So in borderline resectable patients, you can have a neoadjuvant chemotherapy, then you see the response after the chemotherapy cycles, that it is becoming resectable, then you go ahead with the surgery.
Yes.
That is sir is trying to ask you about.
Okay.
So what are the other possible complications during pancreatitis? You can see one you mentioned about delayed gastric emptying. Any other complication you are aware of?
Postoperative pancreatic fistula, sir. Then hepatitis leak, gastrointestinal leaks are rare causes. Then postoperative wound infection, intraabdominal SSI, then splenic artery aneurysm.
So
Will you
post
find hemorrhage?
pancreatectomy hemorrhage,
Hemorrhage.
right?
Yes.
Okay.
And
So
also
can,
pancreatitis is also very common after PD.
yes. Okay. Can you name some techniques of doing pancreatico-jejunal anastomosis, PJ?
So we can ductomucosa, sir, and dunking method.
No, Dr. Mucosa, what are the various names of some techniques? Are you aware of that?
Dunking.
You have seen in your institution.
Sir, ductomucosa, you know.
So you can have a Blumgart or a modified Blumgart technique of PJ, or you can have a Heidelberg technique, right? So currently, Heidelberg technique is very popular amongst pancreatic surgeons because it gives you the minimum leak rates.
Yes.
Yeah, Dr.
Dr.
Kanaga,
Ashish, have you operated this patient?
No, ma'am.
Or you're
just
still
working.
optimizing? Okay. So what is your further plan for this patient, this particular patient right now?
Ma'am, we'll get a CT pancreatic protocol done from our institute, ma'am. And then meanwhile, we are optimizing the patient. Then after seeing the resectability, ma'am, we plan the patient for surgery. After pre-op.
Ashish, what are the various palliations for the carcinoma head of the pancreas?
Sir, for obstructive sorry, pruritus is there, sir. Then we have to by adding some emollients or sir cholestyramine, and sir then we have to for the jaundice, sir. We can do endoscopy drainage, sir, stenting, or we can do PTVD. And sir, for the pain, sir, we can analgesics and NSAIDs, then opioids is not relieving, then we can go for celiac plexus block or neurolysis. And if due to involvement of the gastric outlet obstruction is there, then you can go if the patient survival it is less duration, then you can go for endoscopic gastrojejunostomy. And this way.
Within pancreas, which is the more common site for development of CA pancreas within pancreas?
Head, sir.
Head. So what many percentage of patients will have pancreas in body? CA pancreas in body and tail.
10%.
And what will be the preferred operative procedure for them?
The distal pancreas, total pancreatitis.
Total pancreatectomy or distal pancreatectomy. Tail. In tail, what will you do?
So distal pancreatectomy.
So in which conditions, when you are performing a distal pancreatectomy, you will do a splenectomy with this procedure? What are the indications for splenectomy along with distal pancreatectomy when you are dealing with tail of the pancreas tumor?
There are splenic arteries involved.
Okay, any other indication you know? when you will have to do splenectomy. You cannot leave spleen as such.
So involvement of the hilum of the spleen.
Yes, involvement of the hilum and the lymph node burden, which is more in the hilum, then there is a splenic vein thrombosis, which you have diagnosed preoperatively, right? And then when there is a lot of adhesions between the tumor and the pancreas and the splenic vessels, which you cannot do a proper adhesiolysis, you cannot make a proper plane, right? So in those conditions, you have to resort to splenectomy, right? Yeah, Dr. Kanagabil, sir, you want to ask some question?
No, sir. I think we have discussed most of the things. Unless other faculty wants to ask or give comments, I think we should give Dr. Ashish to ask questions or doubts to be clarified with all the senior faculty here.
Yeah, Ashish, you want to ask any question pertinent to this patient?
No, sir.
Okay, Dr. Sneha, ma'am, you want to ask some question?
No, sir.
Okay.
Muthish Paray, sir.
Nothing, sir. I think you told well. I think.
Yeah, Dr. Ashish, I think you did well. I mean, you're having good optimum things.
Thank you.
Good.
Sir. Thank you. Thank you.
Kanna, sir. Kanna, sir.
I think Ashish has done very well.
Thank you, sir.
Yes.
Thank you very much.
Can we call it a close, sir? Kanna, sir?
Yeah, I think it is already 20,
Okay.
yeah.
Yes, sir.
So-
Thank you, Dr. Ashish and Dr. Nikunj, for contributing your cases today. I also thank Amit Gupta, sir, who have been constantly in touch regarding preparation of the students and sending the PPT. Thank you, Amit, sir. And Vaibhav, sir, and Sneha, ma'am, thank you very much for joining our
Thank you,
platform.
sir.
I wish you could join for GA cases whenever time permits. And this happens on all Fridays. So maybe if any of your students interested also are welcome to present in this forum. And Muthish Paray, sir, again.
Sir, thank you very much, sir.
for
Thank you, sir. Sir,
Any of
thank
your
you.
students who wish to present, please ask them.
Definitely, sir. Definitely, sir. Definitely.
I thank all the students who have been joining online and offline in the YouTube, and Kanna sir and the senior faculty who joined today. Thank you very much. And with the permission, I think few more centers are taking exams. The national board exam is happening nationally on 28th of this month. We wish all the candidates well for the upcoming examinations. This is the time where you should concentrate on the clinical part of it, and of course the ASCII part of it. So candidates spend time reading well. And also, I think the last date is coming up for the NEET SS examination for all the candidates. So wish all of you apply for the NEET SS and in the same momentum get a seat in the super specialty. So on behalf of the faculty, we wish you all the very best for the upcoming examination and for the MSDNB examination as well as the NEET SS examination to get a seat of your choice. Good luck to you, and we sign off this evening. Wishing you all the very best and look forward to have you on board coming Friday. Good night, everyone. Good night, faculty. Good night, students.
Good night, sir.